going to talk about our experience comparing the thermal dose to the lesions during essential tremor cases. During the treatment, the exablate neuro tracks the accumulated thermal dose during the essential tremor and other neuro cases. And it displays two overlays, one at a high threshold at 240 equivalent minutes at 43 degrees, and one at 17 minutes. The lower value is indicating where you have a high probability for thermal damage. The imaging is obtained in a single plane. However, we acquire over multiple sonications and this plane is changed and the focal spot is moved. And we need to be able to track this accurately in 3 dimensions to ensure a safe and effective treatment. A number of other studies have looked at comparing the temperature and the dose with the lesions. And recently, Seasons et al. Published a method where they estimated the 3-dimensional dose by fitting the heating to an ellipsoid. Here, I'm going to talk about our experience from 120 tremor cases and a similar but slightly different approach for tracking the accumulated dose. Here's some thermometry images during one treatment. Here we did 10 sonications in this patient, and we varied between axial and coronal imaging. I'm showing the internal capsule as a reference. And you can see that we also steered the focal point to different locations until the tremor was relieved. And what I did was I took weighted averages of all of the images and the thermometry images and the different orientations. I fit them to a uniform time and spatial matrix and created templates that I could scale by the focal heating. So if I acquire an axial image and I want to estimate the coronal dose, I can then multiply it by this template. Here's some examples of how well this worked. This is T2 weighted images acquired at 24 hours. We can see the lesion and the internal capsule. The dark blue line is the 17 equivalent minutes, 43 degrees contour, and the dotted line is the segmentation. And in this case, I was able to make 4 different templates, and you can see in 3 of them, we had very good agreement between the dose and lesion segmentation. Here I've overlaid the thermal dose and lesion segmentations for 120 cases. Some cases I didn't have the images for this orientation. And here I'm showing in white the lesion segmentation, in red the thermal dose, and pink is where they overlap. And what I did here is I found a patient-specific threshold for each treatment, and that threshold maximized the dice similarity coefficient. And after this optimization, we see that we had very good agreement, and you can see qualitatively that the shape of the dose and the lesion agreed very well. And I had similar results in axial images. However, in some cases, I did see heating going into the internal capsule that wasn't reflected in the lesion segmentations. Here I plot the patient-specific thresholds for the 120 cases, and I sorted them by the amount of shift in the ventricle that I measured after registering the planning images to the 24-hour images. And this is due to tissue swelling over 24 hours. And what I found was after the shift in the ventricle exceeded about half of the thermometry voxel dimension, the apparent threshold for damage appeared to drop. So using this information, I could divide the cases between those that had swelling and those that did not. Comparing the overall for 120 cases for the lesions versus the thermal dose here at 17 minutes, we could see that on average the shapes agreed well, and the difference between the two when all the treatments together were considered was less than 1 millimeter. And for those cases without swelling, it was the RMS error was less than half of a millimeter. The thermal gradient at the location of the 17-minute line was very high, so over 100 minutes per millimeter or 8 degrees per millimeter. So there was a range of thresholds where we could see very good agreement. I then calculated the probability for damage for each voxel in these 120 cases, and the resulting threshold, especially for cases where we didn't have swelling, agreed well with the other studies that I referenced at the beginning, and 50% probability occurred at 17.5 minutes and about 49 degrees in the maximum temperature. This appears to match remarkably well our previous study in rabbits that found a threshold at 17.5 minutes and 48.5 degrees. However, we should note that they had different temperature sensitivities for the thermometry that the device uses versus what I used in the rabbit study. So the threshold here in these patients is lower than we would expect based on the preclinical work. And this difference is probably explained on the method that we use. So that the lesion here, I measured at the edge of the lesion where there's strong gradient swelling. And in the rabbit study, I measured in the center of the lesion. And I'm going to conclude there. And if anyone's interested in more information about this study, it just was published online at Physics and Medicine and Biology.